Okay, so I've been asked to talk about macrotroponin, which is not a topic that I would have chosen for this audience because it means I actually have to talk a lot about lab troponin assays, not point-of-care troponins. But hang in there, stay with me, it's going to be worth it for the punchline. A 76-year-old man presented to ED with chest pain. Now, not all chest pain is cardiac, and this man's ECG and his echocardiogram were normal. But he's 76, he has risk factors, and his troponin was very high at 907. This was on the Roche high-sensitivity troponin T assay, where normal is 14. So 907, that's really high. So he was admitted as a non-STEMI, a non-ST elevation myocardial infarction. He was in hospital for a few days and his symptoms, his pain, got better. But the troponin didn't. The graph here shows that over the course of 5 days, over the course of 5 days, no, that's not going to work. Yeah, that doesn't work. Yeah. Over the course of 5 days, the troponin hovered persistently around the 700, 800 mark, and it never showed that classic rise and fall that you expect with a heart attack. Just this persistently very high troponin. Or was it? Now, as it happened, this lab had a procedure where they randomly ran some troponins on a point-of-care device as well as the main lab analyzer. The point-of-care device was a Roche H232. And on that, the troponin, that was 907, was negative. So now you have two completely conflicting troponin results. Positive on the big, shiny, super-duper Roche lab analyzer, but negative on the little handheld. Which one was right? Well, the Roche instruments run troponin T, so they tried running the sample on a range of troponin I assays, and they were all negative too. So now they're certain their Roche lab analyzer is the one that's wrong, but first they thought it must have been blood. So that's where the patient has an antibody that's interfering with the Roche assay to give a false positive. So they treated the sample with scantibodies. Oops. Sorry, I didn't mean to do that. With scantibodies to harness God's elegant antibody creation, as they say on their website, to get rid of that interference. But it didn't work. The scantibody treatment didn't change that high troponin result on the Roche at all. So that argued against an interfering antibody. So then they did another procedure. They treated the sample with polyethylene glycol, or PEG. Now, PEG works like a big sponge in the sample to suck big molecules out of solution so they precipitate. Hence we talk about PEG precipitation. And mostly the big molecules we're thinking about are big immunoglobulin proteins. So PEG precipitation is another way of pulling out interfering antibodies, but it can do something else. It can also suck out these things we call macroanalytes or macro complexes. We usually use PEG in the lab to detect big or macro forms of prolactin. But it occurred to our colleagues that maybe they were dealing here with a big troponin, a macrotroponin. And bingo, after they treated the sample with PEG and ran it again, the troponin result on their Roche analyzer now fell dramatically. And they were pretty sure they knew what was going on. And the lab was St Vincent's in Sydney, and our colleague was Graham Jones, there on the right. And he was pretty sure he'd found the first example of a macrotroponin causing a raised troponin T result. And this is a part of the poster that he presented at the AACB annual scientific meeting in 2015. As it turned out, this was the same year that some other colleagues, this time from the Mater in Brisbane, were seeing a similar thing with their Abbott Architect high sensitivity troponin I assay. Here's our colleague Janet Warner presenting on this to an AACB meeting in Wagga last year with Anthony Flaskas from the lab there introducing her. And she was speaking on this paper that she and George Marshall published in 2016. And the story there was that not long after they got their new Abbott Architect high sensitivity troponin I assay, they started to get complaints from their doctors about what looked to be unexpectedly high troponin I results. Like the guys at St Vincent's, Janet and George did a range of tests to work out what was going on, but this, and I'm pointing to the graph on the right, is what clinched it for them. They ran some of their suspect samples through a gel filtration procedure that separates molecules by size. And what you're looking at is one of the chromatograms that they got. In this chromatogram, they've actually put two patient samples together, and one or both of those patients recently had some cardiac damage, because there's a peak there on the right, if you can read it, that demonstrates a true troponin rise. You may be able to see they've labelled it troponin IC, because it turns out that the troponin I we're measuring is often actually a complex of I and C. But that's not important in this example. The important thing is that peak on the left, which is demonstrating the component of macrotroponin in this pooled sample. Now, I don't think it was a coincidence that both these labs in Sydney and here in Brisbane were seeing something funny with their troponin assays at around the same time. But hold that thought. So I just want to go back to basics. Troponins ain't troponins. Generally, when we use the word troponin, we're all assuming that we're talking about the cardiac troponins that we test for, the troponin I or troponin T in blood samples. But of course, both of them exist in skeletal muscle as well, although the molecules in the heart and the ordinary muscles aren't exactly the same. And then there's troponin C, which is the same in heart and skeletal muscle. And of course, the vast majority of the troponin in the body is not in the bloodstream where we look for it. It's in living heart muscle cells bound up in the muscle fibres of the cells of the heart, as shown in the diagram. Inside those cells, there's also a bit of free troponin I and T, just floating around in the watery part of the heart muscle cells, the cytoplasm, which is referred to as cytosolic trop I and T. But then when you get into the bloodstream, what we measure, that's different again. So you can get some of that free troponin. You can get bigger complexes like that combo of trop I and trop C that we saw in the chromatogram for the, from the martyr. And on top of that, once the troponin's in the circulation, it can get changed. The amino acids at the end of their molecule can get chopped off, or you can get other chemical reactions like adding phosphates or oxidation reduction reactions. But there's more. You can get troponin molecules binding to other molecules in the circulation, forming big molecules, big macro complexes, which is where macrotroponin fits in. Now, as you know, there are a lot of different troponin assays around. And with so many different troponin assays and so many different forms of troponin, as you would expect, some assays will detect certain forms of troponin better than other assays. I'm not just talking about trop I versus trop T, but all those different troponin I assays, and particularly the older troponin I assays, especially point-of-care assays like the iStat versus the newer whiz-bang high-sensitivity ones that all the labs use now that can detect troponin at very low levels and presumably are pretty good at detecting all those different forms of troponin. Now, mostly, we do want to detect all those different forms of troponin. If they're in high levels in the circulation, it does mean there's been recent damage to the heart. And that's what we want to know when we do a troponin assay, unless you're talking about macrotroponin. Because macrotroponin sort of falls more into this category. If you detect a high troponin in a patient and it's all in the form of macrotroponin, that's actually a misleading result. It all comes back to antibodies. Now, as you know, all the troponin assays we use are based on antibodies that recognise and bind to troponin molecules. Antibodies are really useful in assays because they're good at binding to things, sticking to other molecules. But, of course, patients have antibodies too. And sometimes they have antibodies that stick to reagents in the assay and muck it up. As a general rule, when antibodies muck up an assay, they can make it read either too high or too low. But usually, certainly in the case of lab troponin assays, it's really only the falsely high ones that the doctors ever tell us about. Now, I know that's different from the point of care experience, so just hold that thought because we're still talking about lab assays for a while. So, there's heterophilic antibodies, those sticky antibodies that can bind to lots of things, or there's also anti-animal antibodies that bind to the animal antibodies used in the assay. But there's another sort of interfering antibody that patients can have. They can actually have an antibody to troponin. Now, I remember hearing about anti-troponin antibodies years ago, and then I never heard anything about them again until just the last couple of years. Now, it's not so surprising that people can have antibodies to troponin. We know in autoimmune diseases people have antibodies to all sorts of things. So do healthy people. In fact, we know that roughly 10% of people might have anti-troponin antibodies at any one time. 10% of you listening may well have antibodies to troponin. What does that mean? Well, for a lot of people, hopefully everyone in this audience, nothing. There is nothing wrong with them and there's nothing wrong with their heart. But in some people, they may have had some sort of heart damage and they may have a bit more troponin floating around than usual, and they may therefore develop antibodies to it. Or it can be that the antibodies are actually part of the problem. So in a person that has some sort of autoimmune condition where the immune system, whether it's the antibodies themselves or related immune cells, are actually attacking the heart. But the reason all this matters to us is because those anti-troponin antibodies can affect our troponin assays. Now, anti-troponin antibodies can affect troponin assays in a couple of ways, but one thing that can happen is that if these anti-troponin antibodies are, if you like, strong enough, they can bind tightly to the troponin in the patient's bloodstream to form these big complexes of antibody and troponin, or macrotroponin. I should say it can be an antibody bound to troponin I or to troponin T. So strictly speaking, we should talk about macrotroponin I and macrotroponin T, but for now let's just say macrotroponin. And macrotroponin is certainly currently one of the big things in clinical chemistry. Speaking of big things, I cannot resist showing you this picture I found of some random people on the internet demonstrating the concept of antibodies binding to a troponin molecule using as a prop this other big thing. Any Queenslanders here? It's the Big Apple at Stanthorpe. But macrotroponin, it's a bad Big Apple. Because just like these other big things along the highway, once they become an Aussie icon and everyone loves them, they become very hard to get rid of. And that's the problem with macrotroponin. It's hard for the body to get rid of it. So, even a normal healthy heart leaks a little bit of troponin. Normally it gets cleared out of the bloodstream quickly by the usual body garbage services, so your circulating troponin level stays quite low. But these macrotroponin complexes are so big that they seem to be able to avoid the usual body garbage trucks for longer than the regular troponin, and they just keep building up and building up. which isn't a problem until someone wants to check your troponin level. And even then, it wouldn't be a problem if your troponin assay couldn't detect the macrotroponin, if your assay just couldn't even see the macro, couldn't count it in the troponin result. But if your troponin assay does detect macrotroponin to any significant extent, then you'll get a high troponin result. Those big molecules have given you a big troponin result. And if you haven't had a heart attack, that's bad, because the whole idea of the troponin assay is to check for recent heart damage. But if that macrotroponin is just troponin that's been slowly leaking out of a perfectly normal heart for weeks, just accumulating and accumulating and floating around in the blood, it's not reflecting recent heart damage. That big troponin is a misleading result. Now, how common is this? I said before that maybe 10% of you listening today have anti-troponin antibodies in your circulation. And it's only in some of you that those antibodies may be tightly bound to the troponin so that you're actually accumulating macrotroponin. At the Mater in Queensland, they thought that maybe 5% of the raised troponins they were seeing on their Abbott Architect high sensitivity assay were raised because the assay was detecting macrotroponin. 5%? That sounds reasonable enough to be worried about for me. Some people think it could even be a higher percentage. The results they got in Queensland from their macrotroponins was mostly under 100 on the Architect, where the cut-offs are 26 and 16. So it's not extremely high, but high enough to worry about. And sometimes it's much higher, as we saw in the example at the beginning from St Vincent's. So it's a problem. What can we do about it? I'll just take a step back and say there are lots of problems with troponin assays. Yes, I've used this slide before, for those of you who've seen my talks before. And I should stress again that while interferences can make test results go high or low, we're talking here about troponin results that the doctor thinks are unexpectedly high. And usually we mean not just that the number is a bit higher than they're expecting, but the result is actually a false positive as opposed to a definite negative result. And of course, given today's topic, I'm still talking about false positive results on a lab assay in a lab here. Now, some of these are easy to deal with. There are the usual suspects: hemolysis, clots, carryover, random errors. And we address those by all the usual methods, the 3 R's: respin, reanalyze, recollect. Then there are the antibody-related interferences, like the interfering antibodies, the heterophilics, the anti-animals, and the anti-troponin antibodies, and specifically what we're talking about today, their role in forming macrotroponin complexes. They're a little bit trickier to deal with. Now, this is the hard slide, but don't worry about the details of all this if it sounds like gobbledygook. Just to show that there are lots of things that the lab can and should do if we think we have an interfering antibody or a macrotroponin causing a high troponin result. Mostly the doctors are happy if we just do something to check the result and tell them if we think it's really right or wrong. They usually don't want to know why a result was wrong. But sometimes we can put 2 and 2 together and work out what might be going on by a series of tests like the ones I've outlined here. So starting with a relatively simple test of serial dilution of the sample. Now, if the results are non-linear on serial dilution, that suggests an interfering antibody. It doesn't really help if it's a macrotroponin. If it's a macrotroponin, the serial dilution will be linear, just like for a normal troponin. Then some labs will have access to scantibodies, which are supposed to remove heterophilic antibodies. If you treat the sample with scantibodies and run it again and the result comes down, that suggests a heterophilic antibody interference. If the result doesn't change, it could be a true result. It could still be a macrotroponin. Polyethylene glycol we've already mentioned. That's the sponge that sucks up high molecular weight stuff. Now that will remove heterophilic antibodies and any macrotroponin. So if the troponin level comes down after treatment, you know the result was falsely high, although you won't know why. If it doesn't change significantly, then that's good evidence that it is indeed a true result. PEG, it's a bit rough and ready. A more specific method is precipitation with an immunoglobulin binding product. And again, if the result comes down after treatment, you'll know the result was falsely high. You just won't know why. Then there's gel filtration chromatography. That was the method they used at the Mater in Queensland, and that's the method that gives you pretty definitive evidence for a macrotroponin. Now, most labs won't be able to do that. That's why there's talk about setting up a national reference lab for this sort of fancy testing. Unfortunately, the RCPA working party that was looking at this hasn't really done anything at all this year about this because of the whole COVID thing. So watch this space. That might be the topic of a future talk. Then last but not least, I've snuck in the old trick, analysis by an alternative method, something any lab can organise. With a bit of luck, you'll pick an alternative method that behaves very differently to the original assay that you used. And if you get a different answer on your alternative method, and it's an answer that fits better with the clinical picture, that does tell you there's something wrong with your original result. Now, I know we've all been told that you can't compare different troponin assays. And in fact, what I've been saying today about all the different forms of troponin hopefully has convinced you even more about that. But what I'm talking about here is not comparing the actual numbers, but just comparing whether a positive result on one troponin assay is positive by another troponin assay. And I think it's reasonable to expect that our troponin assays will mostly agree whether a sample's positive or negative, except of course at those very low levels with the high sensitivity troponin assays. So if you think there's an interference affecting your troponin assay and you want to compare it with a different assay, how do you choose the alternative assay? Well, there are a lot of different high sensitivity troponin I assays around, so that's an easy option. And it's possible that a macrotroponin will be detected by one high sensitivity troponin I assay, but not another. In fact, if your lab has an Abbott Architect high sensitivity troponin I assay, as we do in the north, then this is a good option because our assay seems to be particularly prone to detecting macrotroponin. I think that a better option may be using a high sensitivity troponin T assay if you started with an I. Remembering that if you're thinking the patient had an unexpectedly high troponin on a trop I assay, chances are they don't have a macrotroponin T and vice versa. So maybe a troponin T is a better alternative to a trop I. I can tell you it's certainly easier to explain what you're doing to the doctors, and that's actually why I prefer it. But remember that if you want a troponin T assay, you're really looking for a Roche assay, so there are limited options. For us in Newcastle, we have to send them to Sydney, and with the best will in the world, that's only going to happen so fast. But there's another option, an easier, quicker option that's been sitting there right under our noses all the time. Hallelujah! Hallelujah! It's an I-stat! It's an I-stat. I can't hear you singing along, guys. As far as we know, the I-stat does not detect macrotroponin. Now, you may have difficulty convincing your clinicians of this. It's not in the textbooks, and I haven't even seen it in a journal article yet. Please, if someone has, let me know. But I can tell you that I've heard it from several different colleagues, and I've heard it from Abbott, and it kind of makes sense. But why? Spoiler alert, I haven't been able to find out for sure, but here's what makes sense to me. If you picture what a macrotroponin is, it's a troponin molecule with a huge, great antibody hanging off it. Here's a diagram illustrating a troponin I molecule. So that's, can't point, but from 1 to 209 amino acids. With a big antibody from the patient there at the bottom, the big grey thing hanging on to form a macrotroponin. And there at the top are the antibodies from an assay, in this case the Abbott Architect High Sensitivity Troponin I, trying to get to that site that they need to bind to. And you can see how that huge great antibody hanging down off the bottom may make it hard for our assays to see the troponin, to allow those antibodies, the capture and detection antibodies, to get down to those sites they need to get to. Now, I mentioned earlier that this whole macrotroponin thing really only seemed to start when we got high sensitivity troponin assays in the labs. As you know, the whole point of these assays is to be better at detecting low levels of troponin and presumably detecting all those different forms of troponin that we want to detect. But maybe something else has happened. Maybe they're also detecting the form that we don't want to detect, the macrotroponin. Maybe whatever the manufacturers have done to tweak their assays has meant that the binding of the antibody in the assay to the troponin molecule is so strong that it can kick off. I'm flicking that big antibody at the bottom of the screen to kick off the patient's own anti-troponin antibody, and bingo, you've got rid of the macrotroponin in the sample, and now it just looks like regular troponin. So if you want an alternative troponin assay that's less likely to pick up macrotroponin, then you could try one that doesn't claim to be high sensitivity. Of course, all the lab assays now are high sensitivity, but we still have point-of-care devices that aren't, like the Roche point-of-care troponin T I mentioned in the St Vincent's case at the beginning, or our own iStat. And it does seem that these assays from an older, simpler time just can't see macrotroponin. Maybe it's because their antibodies bind at different sites, although that doesn't explain the Roche example. Maybe the antibodies just aren't strong enough to be able to kick off the patient's antibody. Maybe there's something special about how point-of-care devices work. Now, I'll admit that part of the story might just be that a lot of macrotroponins we're picking up on high sensitivity assays are way down at those low levels where the point-of-care assays are a bit dodgy anyway. But certainly at higher level troponin results, say over 100, that's nanograms per litre on your lab analyzer, or 0.1 in iStat units, if you want to exclude a macrotroponin, the iStat might give you the answer. The iStat might just be the one that's right when the lab analyzer is wrong. So we don't have all the answers, and I'll give Elton John the last word.